This 24-year-old lady, postgraduate, who had this trivial fall at home, seen at another center, planned for THA after initially considering some non-operative treatment. The hip was opened. They attempted acetabular reaming. They abandoned because of poor bone stock, and the patient was referred to us for further treatment. This was the X-ray. She came to us. We did an initial blood workup. Because her bone stock, if you look at the previous X-ray or look at the X-ray, was looking osteoporotic. Creat was 0.45. Her T4 was 6.9. Alkaline phosphatase was 127. We got the endocrine people involved. And on clinical examination and full assessment, they found that she was a patient with thyrotoxicosis and Graves' disease on treatment with carbimazole 40 milligrams once a day. So we had worked her up for the surgery. We had also done a beta cross labs which were marginally elevated. The other parameters were normal, parathormone and otherwise. CRP was less than 3.3, so without any infection. We got a bone mineral density assessment done, which the endocrinologist told us that we'll plan for zoledronate post-op because our BMD was low. Pre-op X-ray was showing that the affected limb was osteoporotic. We wanted further evaluation, so we got a CT evaluation done because we were not sure, because the reaming was done supposedly for the acetabulum, but we were not sure what exactly was the acetabular bone stock. So we went ahead and got an acetabular CT done, which showed there was adequate walls anteriorly and posteriorly, so we didn't have to really worry about it. The fact remained that there was no head, so there was no autograft available for reconstruction if required. So that's why we did a CT.
So just wait on. We'll ask the panel exactly what they would. Anything you want to present before managing the discussion?
No.
So, Pradeep, you can start. What will you do? Quick. We have to see.
Yeah, THR hybrid, trabecular metal coated cup and cemented stem, ideal for cemented stem.
Amar, anything different?
I agree. This is a case I'd probably do a hybrid. The socket's a little bit challenging. It's going to be a small cup. You could have a small head, but that's just the reality that you're in.
Yeah, it's certainly a metabolic workup because of the trivial fall, but this, one side relative osteoporosis doesn't worry me. That's because of deloading. The other side bone looks reasonably okay. So I'm not too worried about that. And if I can get non-cemented fixation, I would be happy to do that.
On the stem side, cemented, and on the acetabular side, uncemented, trabecular.
Yeah. Anything differs from this?
On-table assessment of the stability of the covered stem.
Anybody differs? No, they agree. You can go ahead.
Yeah. So the planning was basically we ruled out infection. We were ready. In fact, if there was any evidence of infection, we would go ahead and stop. We templated. It was showing roughly about a 44, 46. That's exactly what we did. We got a reasonable fixation, 46 size cup. Obviously, the stem side had to be cemented because there was absolutely no stability and it was looking very osteoporotic. We did send cultures, final report, no growth. 3 months post-op, her beta cross labs are also coming down. There's a 1-year follow-up on her, and she's doing well. She's basically continuing her treatment and going ahead with her thyrotoxicosis treatment as well. So basically, the trivial fall in the fracture neck, the take-home message was evaluate, detailed assessment, planning, templating. You have to keep all the options available, and cemented backup is definitely a good option. Definitely to be considered in patients with metabolic bone disease and poor bone stock.
Any comment from the panel?
The only thing I didn't like was your cemented stem. The metaphyseal area was a little bit high up on the femur, but other than that, it looked very good.
Yeah, I think we got that.
Thank you, Anil.